Is it okay if we go ahead and get going here, Amanda?
Let's do it.
All right. So I'd like to welcome everybody to Pediatric Grand Rounds. And a couple items of housekeeping before we get started. If folks could log into the CME system that's in the calendar schedule, as well as the email invitation that helps us track attendance, and also hopefully in the future justify food and keep the audiovisual system going. So it would be greatly appreciated, even if you're not claiming CME at this point. Dr. Shoubaki today as well has no conflicts of interest to declare, so that's good. So today it's my pleasure to introduce Amanda Shoubaki. She's one of our third-year residents here at ETSU. She went to the University of Mississippi for undergrad, and then the William Carey University College of Osteopathic Medicine, which is in Hattiesburg, Mississippi, for medical school before joining us here. During her time here, she's participated in the Constipation Order Set Quality Improvement Project, as well as presented a poster on seizures as a presentation of neonatal hypoparathyroidism, which is definitely an unexpected presentation. So, but Dr. Shoubaki is going to Laurel, Mississippi next year to practice primary care pediatrics, and she is here to talk about COVID-19 in children. So I will turn it over to her.
Awesome. Okay, guys, I'm gonna share my screen here and actually stop my video so that I make sure our connection comes through clearly. So let's see. Give me just a second. There we go. Okay. So, as Dr. Dodd said, I'm Dr. Shoubaki, and this is my presentation, Unmasking the Effect of COVID-19 on Children. I have no conflicts of interest to declare. So the goals of today's presentation, I want to talk a little bit about the ways in which the current COVID-19 pandemic has impacted children, and hopefully by the end of this presentation, we'll be able to kind of weigh the current measures in place to combat the pandemic with the potential long-term outcomes of them. So first, I'll kind of go over some COVID-19 statistics, then talk briefly about the environmental impact of COVID-19, the developmental impact, and then the impact of distance learning on children, as well as the mental and emotional impact of COVID-19. So how has COVID-19 affected children as a virus? Per the CDC, as of November 12th, the cumulative number of COVID-19 cases in children is about 1 million, which makes up about 11.5% of all cases. The overall rate is about 1,300 cases per 100,000 in the population. 10 states reported on testing, and in those 10 states, children made up between 5 and 17% of all state tests, and between 4 and 18% of children being tested were positive. 23 states in New York City reported on hospitalizations for COVID-19 in children, and between 1 and 3% of total hospitalizations were in pediatric patients, with between 0.5% and 6% of all COVID-19 cases in children resulting in hospitalization. And in that statistic, it's important to remember many of those children have pre-existing conditions or other things that led to COVID-19 being more severe of an infection for them. 42 states in New York City reported on mortality. And in those states, children were between 0 and 0.21% of all COVID deaths. 16 states reported 0 COVID deaths. Here in Johnson City, we've had only 1 COVID-19 death and a kiddo that I'm aware of, and she was struggling with many other pre-existing conditions. And in states reporting between 0 and 0.15% of all COVID cases in children resulted in death. So in summary, over 1 million children have tested positive for COVID-19. Overall mortality remains low in the pediatric population. And per the CDC themselves, there's an urgent need to collect more data on the longer-term impacts on children, including ways which the virus may harm the long-term physical health of infected children, as well as emotional and mental health effects. So we're going to kind of talk about that. The economic impact of COVID-19, just briefly, small business revenue is down 20%. By about July, 420,000 small businesses failed, which is usually the number seen in an entire year. New business formation is down. Layoffs, shutdowns, and decrease in hours are common. Many of our patients have experienced at least one of these in their family. Unemployment tripled from January to April, and the people in the workforce searching for a job rose by 4.5 million in April and remains elevated today. In 26 states, more than 20% of people, or 1 in 5, were behind on rent. And food insecurity doubled for families with children from 2018 to July 2020. So how does this specifically impact our families? Low-income families with children were the most likely to experience income shock, with more than 60% of these households experiencing income shock due to COVID-19. Each additional child in the household increased the likelihood of a serious delinquency, which was in the study classified as being more than 2 months behind on mortgage or rent, by 17%. And if you look over at this figure, you can see that the share of families experiencing income shock is not even across the board. Non-Hispanic white families were the lowest risk of experiencing income shock, with Hispanic families being the most at risk, followed by non-Hispanic, Black, and other. This is from Brookings.edu, by the way. You can see by the figures about half of Hispanic households and Black households experience income shock. Hispanic families were the most likely, saying that in 61% of their households that someone had lost a job or had their wages decreased. And then if you look at the share of families experiencing income shock by income, you can see that nearly 80% of families at the poverty line experience income shock, compared with only about 30% of families living in the $200,000 and above range. Significantly, this is also the group of people who don't have savings and usually live paycheck to paycheck. So income losses related to COVID-19 are associated with a host of material hardships, including food insecurity and difficulty paying bills. If you guys remember back at the beginning of the COVID-19 pandemic, while all of us who could afford it were panicked buying toilet paper and rice, we had several families that came to our clinic asking us if we had any formula to spare or any diapers to spare. We were calling WIC offices that said they were just out of formula. So this was creating real food insecurity for our families with low income who were trying to meet the basic needs of their children. Poverty has a dramatic effect on children. They are more likely to have hospitalizations for asthma, more likely to be behind on the growth curve initially, and then to be overweight later in life. They have increased neonatal and post-neonatal mortality rates. There's a greater risk of injuries resulting from accidents or physical abuse and neglect. They have lower developmental scores over the years in a range of tests. They have lower overall academic achievement. They're more likely to have impulse control disorders. For example, they're at a higher risk of having difficulty with self-regulation, executive function, defiance, and impulsivity. They have poorer social relationships. And then many of these children have higher ACEs, which we'll briefly discuss in a minute. They have lower potential lifetime earnings. Children who do not complete high school are more likely to become teenage parents, be unemployed, be incarcerated, all of which have heavy personal and societal costs. The economic cost of child poverty was estimated basically by using future lost productivity and increased social expenditure, and estimated conservatively that about $500 billion a year is lost due to child poverty based on decreased productivity of the individuals and also increased costs of crime and healthcare in these people, and that's actually about 4% of the GDP. So the societal impact is huge. Back to ACEs, though, the personal impact of poverty is huge. ACEs stand for Adverse Childhood Experiences, and most of us in pediatrics, and hopefully all of us, have some familiarity with ACEs. ACEs come in 3 types of categories. There's abuse, which can be physical, emotional, or sexual. There's neglect, which can be physical or emotional. And then there's household dysfunction, which can be related to an incarcerated relative, divorce, witnessing mother treated violently, substance abuse, and mental illness. COVID-19's had quite an impact on basically every single one of these categories, including elevated divorce. BBC said that one of their largest law firms in the UK saw a 122% increase in inquiries for divorce between July and October of 2020. And here in the US, a major law firm saw a 34% rise in sales of its basic divorce agreement, with up to 20% of those sales being to newlyweds who got married in the last 5 months. So the pandemic has been hard on families, not just on the children, but on the parents in the home. The kind of pandemic breakup phenomena is definitely real and is affecting the children's kind of family security. Another really unfortunate effect of childhood poverty is child trafficking and exploitation. Approximately 10 million children are victims of child trafficking and exploitation at any given moment. And based on survivors that we're aware of, about 15% of trafficking victims are boys and non-binary youth. So this is likely not a women and girls issue. In the US, we know, again, based on the survivors, that children of color are about 4 times more likely to be trafficked than white children. And children are much more likely to be trafficked by someone known to them rather than the scenario of being kidnapped and forced into trafficking. In the US, especially in poorer states and cities, family exploitation is the most common form. So there was some discussion, some social media posts, basically implying that COVID-19 was leading to an increase in child trafficking of the kind of stranger abduction variety. We don't have any data to substantiate that whatsoever, but we do know that masked children are easier to transport without identification of them. And what we think is probably the bigger risk is that fewer reports are being made due to the isolation of victims. So I don't think that COVID-19 has led to an increase in kind of stranger trafficking, but we do know that right now children in their homes are very vulnerable and aren't being exposed to the scenarios that would normally lead to reporting. So they're not coming to the doctor's visits, they're not going to school, they're not going to the park, they're not going to social events with other children where someone might see something and report it. And then we know, obviously, the increased financial pressures of low-income families increase the risk that children will be trafficked or abused or exploited by their families. This was unfortunately kind of showcased in my home state of Mississippi, where a woman drove her 16-year-old niece to Texas and kind of hooked her up with a pimp where she was forced to engage in sexual intercourse for $300, and was fortunately able to call the authorities after that. But this is just one example that made the news, where children are being trafficked by their own families. And then the last kind of form of child trafficking or exploitation that I want to bring attention to is that the new kind of method for exploiting children never involves the perpetrators making any contact with the children physically, but they approach them online, they befriend them, they solicit images from these kids, and then use those images or fear of harm to their families or to themselves to elicit increasingly pornographic material. And these children who are at home distance learning are at increased basically vulnerability to predators due to having increased time online. And I think we're going to start seeing a big uptick in reports, at least of the online exploitation nature. It's also important to remember the global economic impact and impact of poverty globally on children. Dr. Mills kind of shared this article with me, so if you're listening, Dr. Mills, thank you. It's from the New York Times, called "Starving Children Don't Cry." And he basically kind of reminds us of the ripple effect of shutdowns. When developed countries shut down, developing countries are the ones who kind of see the most dramatic effects. So according to the UN, the last famine recorded was in a small part of South Sudan in 2017 and lasted only a few months. Now we're on the brink of famine in Yemen, South Sudan, and also Burkina Faso and northeastern Nigeria, with 16 other countries slightly behind. According to UNICEF, approximately 10,000 children a month will die of starvation in the coming year. A group of economists and humanitarians basically crunched some numbers and said that with a moderate scenario of what lies ahead, an additional 168,000 children would die of malnutrition because of the coronavirus. Additionally, tuberculosis, malaria, polio, AIDS, and vitamin A deficiency are poised to make a resurgence due to lack of preventative medicine and vaccines. Additionally, due to poverty and decreased involvement of basically developed countries' programs, 13 million additional girls may be forced into child marriage. An estimated 2 million more girls may endure genital cutting, and 15 million more unintended pregnancies may be the result of decreased access to contraception. The World Bank also estimates that 72 million children may be pushed into illiteracy. So it's important to remember that while the COVID pandemic is something that we're dealing with here in the US, and that our concern is for our children here and our patients, that there is a global impact as well. I want to kind of switch gears briefly and talk about the impact of COVID-19 on development. Again, like the CDC says, there's really not a lot of data on this yet. So a lot of what I'm going to talk about with the development is speculative based on what we know should be happening in development, and based on other factors that we know kind of what happens if children don't meet these developmental milestones or get these opportunities. So social development in children begins at birth. Children prefer their mother's face immediately, and they can actually pair her face with her voice within about 9 minutes of being born. By a month of age, children make eye contact and have an improved ability to focus. They prefer faces to inanimate objects, which just kind of demonstrates that facial contact, kind of face-to-face contact, is a huge learning tool for children. By 2 months, they'll make facial expressions which are largely unintentional, but they'll try to imitate facial expressions of people, but not characters on TV or dolls. So they can tell the difference in facial expressions of real people versus on the television screen. They're interested in conversations, and they'll take turns making sounds. They'll have their first real smile. By 3 months, the imitation of faces continues. Sound imitation improves. By 4 months, they'll reach to be picked up. They recognize emotion and will sometimes mimic the emotion. So this was a super fun age for my daughter Sophie, where if you caught her right as she was starting to get fussy and you made some exaggerated goofy faces or smiley faces, you could almost kind of trick her out of being fussy. She would start parroting that smile, and then it would just become a fun game. By 5 months, kids will have their first laugh. They can also demonstrate anger, and they'll start to begin to show a different personality around familiar people than they do around strangers. By 6 months, they can fake cough for attention. They'll imitate play with toys. They begin to have the emergence of joint attention. They'll stick their tongue out at caregivers, and they turn their head when their name is called. 7 months, they'll have increased attention-seeking behaviors, and they'll begin to demonstrate fear of strangers, maybe loud noise or new toys. 8 to 10 months, you'll see facial expressions for interest, joy, surprise, anger, sadness, disgust, and fear. And they'll have an increased stranger anxiety and improved joint attention. They can also interpret emotions and intentions. So based on looking at your face, they can tell, oh, did they accidentally move that toy that I wanted, or was that intentional? Or which is really interesting. By 11 to 12 months, they'll have increased independence from caregivers as they're becoming more mobile and they want to learn and explore more. By 15 months, they can demonstrate empathy and pride. By 18 to 24 months, they can do pretend play and demonstrate social etiquette, such as saying thank you for a toy they didn't actually like. By 30 to 54 months, they have improved impulse control, begin to recognize gender roles, and start testing the limits. They engage in symbolic play. They start to form their first peer relationships and have more interactive play. So by age 3, they can play with 1 or 2 peers with turn taking and joint goals. They'll start to have imaginative play like pretending to be a cat. They'll also start to demonstrate improved cooperation and sharing by around age 4. And they'll also play tricks on others and fear being tricked themselves. They can also play with 3 to 4 peers and have improved rule-based play. By age 5 to 6, they can follow simple rules and learn adult social skills like giving praise and apologizing. They also like to spend more time in peer groups and begin to understand how they relate to their friends, such as sharing a name or sharing a favorite snack. By 7 to 8, they have a thorough understanding of rules and a deeper understanding for relationships and responsibilities. They develop improved coping skills, and they'll actually find best friends or close friends with whom they share commonalities such as gender, etc. By age 9 to 10, they have peer and friend groups that take precedence over family, and they have an increased desire for independent decision-making and independence from their family. So if you're kind of following along going, okay, why do I care? I kind of like to think about this as what should happen with development, and then COVID-19 kind of comes along and derails that. And I'll kind of talk about the ways in which it derails some of that here coming up. So early on development has a lot to do with facial expressions of caregivers. So in one of the articles I saw, it kind of demonstrated this really well, an interaction between a 6-month-old and her mom, and it described the mom sitting there holding her and talking to her, and it said the infant stared intently at her mother's face, watching her mother's mouth move, listening to the sounds that came out of it, and then shifting her gaze to the mother's eyes and eyebrows that were expressing happiness. Occasionally the infant smiled and showed a smirk, which was followed by the mother responding with such a big smile and a soft but emotional tone. And basically said in this brief interaction, it's a great example of just how much information infants are getting from the faces they see every day. So they're learning how to identify people based on their facial features, their skin tone, the shape of their nose, their chin, and they're also learning different things like micro expressions, eyebrow movement, the upturned corner of the mouth, smiles and frowns. The first stages of language development are watching mouths move to sound. So that's how they learn, how to form the different sounds. Studies have shown that bilingual infants focus on the mouth earlier and longer than children in homes in which only one language is spoken. Babies also learn that faces have names like mom and dad. They learn shared attention better when they can see our expression. So if I'm wearing a mask or part of my face is obscured and I'm looking at something, an infant doesn't really know whether they care to look at that same thing or not, where if they can see, oh, my mouth is open in surprise, or I'm smiling, they can see, oh, maybe this is something I would be interested in too. Children have such a strong facial preference right from birth, and that means that faces are basically the most influential learning tool. Studies done with newborns as early as 9 minutes after birth showed that they had a facial preference by basically holding up paddles with images of faces and then images of scrambled faces. And the infants looked longer at the images of faces than the scrambled faces. Again, kind of talking about that mother voice bonding, they also did the same thing with a paddle, holding up a picture of the mother and also holding up a picture of a woman who looked like their mother. But what was interesting about the study is the infants only looked longer at the paddle with the picture of their mom, if they had seen their mom's face paired with the voice that they obviously had been hearing in utero for 9 months. So this bonding does require a face-voice association. The foundations of language, emotional connection, and attention and socialization are all built in the first year of life, and they're built on facial expression. Studies also show that facial attention has a huge impact on behavior down the road. So for example, more attention paid to faces at 7 months of age. These infants were more likely to show helping behaviors at 2 years of age and less likely to have poor behavioral outcomes at 4 years of age, which sort of implies that children who spend more time looking at faces have more empathetic behaviors and also understand how to pick up on the emotional cues of others. So again, babies learn lots of lessons from faces over time. We just talked about kind of the first months of life where they learn who their parents are, which they associate with consistency and safety. But and they also learn to pair emotional faces with voices. Kids are actually very good at this. They showed newborns images of faces with different facial expressions such as sadness, fear, paired with a voice that demonstrated that emotion. And some infants were actually able to pair these together, so a sad voice with a sad face. Infants became basically competent in this by 5 months, being able to pair the voice clip of an emotion with a face to correspond to it. And by the time they were 5 years old, the ability to recognize and label facial expressions approaches adult competence. And this basically means that we should make sure that we're providing a supportive learning environment with lots of interactive face-to-face time to teach infants like the important skills for development, empathy, and understanding emotion in others. In the second half of the first year of life, infants continue to learn a significant amount from facial expression, like how to handle uncertainty. So they did a study basically where they showed infants who were crawling or cruising or walking a dangerous or potentially dangerous slope, and the infants would only attempt to descend the slope when they looked over at their moms and their moms gave them encouragement, so a nod or a smile. And the ones whose mothers looked concerned or didn't offer any reassurance, the infants didn't even attempt to descend the slope. This interaction right here is actually kind of what was the impetus behind me choosing to do this as my grand rounds, because for job interviews I had to fly with Sophie when she was only about 4 months old, and as we would do things like board the plane or ride the train, or the voice would come over the intercom, every time she would kind of look over at me to see how I was reacting to it. And due to the COVID-19 pandemic, I was wearing a mask, and it really bothered me that I couldn't offer her that visual reassurance. And so I started to wonder, how is COVID-19 affecting kids who are looking to their parents for reassurance, who are looking at the world around them and not seeing the world as it's meant to be seen. And in our outpatient clinic, I kind of continued to see this when we would, be doing physical exams on children or doing different things that children would look to their parents for reassurance. And in older children, they can kind of still gather that verbal reassurance from their parents, but in very young children, they look to their parents for visual reassurance. And that's just one way in which we might not think about it, but COVID-19 is impacting the development of children. Another interesting lesson that children learn from a very young age is like a preference for races or for facial symmetry. So kids actually can distinguish from from about 3 months, what faces are quote unquote attractive or unattractive, which usually means symmetric. And they also start to develop a preference for their own race, which was demonstrated by an inability to distinguish facial expressions in people of other races. They think that this is basically due to the perceptual narrowing. So our brains are really good at figuring out what we need to know on a day-to-day basis and what we don't. And what they found is that children who are exposed to, basically children become experts at reading facial expressions of the people they see every day. So they become experts at reading expressions of mom and dad, but they lose the ability to distinguish facial expressions of people that are unfamiliar from them. And so in infants, this kind of results in the perceptual narrowing, and they have difficulty distinguishing whether two pictures of different emotions are actually the same person or not, if the pictures are of another race. The good news is that this can be reversed if babies are exposed to people who are different from them early and often. However, that's not been the case since the start of the pandemic, where we're socially distancing and we're wearing masks in public. So really, your infant is only learning to identify different facial expressions of the people that they're seeing without masks in your home. So they'll be experts at determining your facial expression, but this may lead to kind of the long-term impact of maybe being less empathetic, or at least not as good at determining facial expressions in people who are different from themselves. Babies continue to develop the ability to read facial expressions into adolescence. So for example, they can determine happiness, sadness, and anger by age 6 to 7. They actually don't consistently identify surprise until age 8 to 9. Disgust comes around age 14 or 15. And people can't consistently identify a facial expression of fear until they're about 16 years of age. So that's pretty interesting. And basically one of the research papers that I was looking at talked about how infants are so good at picking up on expressions that we ought to be careful about what face we're wearing. And so it suggested that maybe they see your fear response in response to a spider, or they see the annoyed look that you have when dealing with a sibling, and basically said, we should be careful what faces our children are seeing. And in the view of the COVID-19 pandemic, our kiddos may not be seeing many faces, and we have precious little face-to-face time with them, and so we should be especially careful about kind of what nonverbal communication we're sending them. And then the last kind of developmental thing I'd like to touch on briefly is language development in children. And a lot of this is kind of stuff we mentioned before. But newborns mostly communicate through crying, but they're already learning about spoken language. They can copy mouth movements even as newborns. And by 2 to 3 months, they'll begin cooing, and they'll start taking turns making sounds. By 3 to 4 months, they'll imitate sounds, and they start to develop consonant sounds like B, K, M, and G. Again, based on watching the mouth movements and correlating that with the sounds that come out of the people around them, the caregivers. So they may not be developing these consonant sounds as early as they're supposed to if they're not seeing these. So we should be screening our children, making sure that kiddos aren't falling behind in terms of language development. They'll start to blow through their lips and may blow bubbles to practice using and controlling their lips and mouths. Around 5 months, they develop the musical sound and speech patterns of their caregiver's native language, and they'll start imitating their first sound patterns and begin using nonverbal cues to communicate their thoughts and feelings. So they may cling to their caregivers or push them away or turn their heads if they don't like something. By 6 months, they'll start to babble and connect sounds together. They'll imitate sentence length and intonation, and they'll learn how to form verbal thoughts. By 7 months, they'll become better at conversating. They'll take turns, quote unquote, speaking, and they can imitate animal sounds. By 8 months, they can connect sounds to actual ideas like milk, and they'll start to build sounds into words such as dada. And again, with the right exposure, they'll start to add sounds such as T and W. By 9 to 12 months, they should have their first words like mama or dada. And their receptive speech at this age is much more developed than their expressive speech. So they can say 2 to 12 words, but they understand hundreds more. And they'll begin pointing or nodding to communicate their agreement or disagreement. And they'll show word and sentence comprehension. Like, for example, they'll point to a picture of a dog when asked, or they'll nod their head if asked if they want a cookie. So why does this matter? Because language development has a significant impact on outcomes for children. Better language is associated with more academic achievement and better peer relationships. Children with better language have higher school completion rates and higher average degrees earned. They have better paying jobs. And language impairment is associated with psychosocial and academic problems. We often see kids with speech delay have temper tantrums as toddlers or young children. And then as adults or older children, these kiddos are more likely to experience disciplinary action at school or to have relationship problems as adults. And this is due to the difficulty in expressing themselves. So that is a little bit about kind of how COVID-19 is potentially impacting kids early in development, with looking at developmental milestones. Another huge way in which COVID-19 is impacting especially older children and adolescents is distance learning. Distance learning is one of those topics that we're just now starting to get some numbers back, and they're concerning. We don't have a lot of data in a lot of states, but in the states that we do have data, the percentage of failures doubled or tripled in Houston area schools. About 25% of students are failing at least one class in San Antonio, and about 12,000 Austin district students are failing at least one class, compared to 70%, and this is a 70% increase from last year. In Maryland, for low-income students, there's 6 times the failures in math and English. More than 36% of ninth graders from low-income families failed with the first grading period in English, compared to 6% last year. So again, that's about a 6 times increase. In Alabama, we have really good data that kind of breaks this down racially, because Montgomery has a fairly diverse school district. It's roughly 32% Hispanic, 27% white, 21% Black, 14% Asian, and 5% identify as multiracial. And in Montgomery, Black and Hispanic students from families at or near the poverty line were the most severely affected groups, along with people for whom English is a second language. Nearly 45% of English learners failed the first period in 9th grade math, compared to only 8% last fall. And for 6th grade math students, Hispanic students from low-income families were the most impacted by the online mandate, with failures jumping to 24% from 4% last fall. For white and Asian students, by contrast, with families not identified as low-income, last year less than 1% of the group failed, and this year was slightly more than 1%. So that's a glaring difference based on socioeconomic status and race in the failure rates after the distance learning mandate. Among the difficulties facing online learners, many feel that the volume of independent work or screen time is overwhelming, and some, especially in low-income families, are trying to balance new household duties, technology glitches, and jobs. Decreased access to teachers and tutoring also is having a big impact. Many of these students, their families have not been able to quit work and help them at home, or they may not have access to reliable internet or reliable laptops or tablets. Again, in Alabama, with respect to the special education population, for children requiring special education services, there is a 16% failure rate for 6th grade math, which is up from 6% last year. And in 9th grade English, the failure rate jumped from 6 to 32%, with many who passed last year failing this year, which basically just means it's not the same kids getting held back multiple years in a row. This is a group of kids who succeeded last year with face-to-face learning who are no longer able to succeed with distance learning. In Arlington, Virginia, they noticed slight overall performance drops in literacy for kindergartners, first and second graders, but these declines were much steeper for non-white students and English learners. Hispanic students meeting the benchmark on these literacy tests dropped 15 points to only 60% passing, and Black students hitting the mark dropped 10 points to only 78% passing. English learning students in the first and second grade had even more dramatic declines, with drops of 26 to 30 points. So in summary, distance learning is furthering the education gap There's a rise in enrollment in online schools and private schools. Many private schools are still continuing to have face-to-face instruction, and many of the online private schools have been in the online format for longer and have much more experience and more resources than do our public schools, who are struggling and straining to make this happen for our kids. In addition to just the distance learning, there are many school-based services impacted by COVID-19. So school-based therapies have been impacted, such as speech, PT, and OT. The U.S. Department of Education Office of Special Education Programs stated that if a local education authority closed school for the general education population, they were not required to continue to provide services to students with disabilities during the same period. So in other words, for as long as our schools are in distance learning, they're not required to do any special education accommodations for our students. Now in our area, many of the schools are trying, but based on the patients that we've seen in clinic and kind of talked with them about therapy, and also based on talking with therapists that we know as well, this has been really difficult. Initially, they were trying to do in-home therapy, but as COVID cases climbed, this was transitioned to online-only therapy. And many of the children are no longer receiving therapies at all. Special education classes, again, no longer required to make accommodations. Not required to make accommodations for IEPs or 504 plans. There's no more access to after-school tutoring or Head Start programs. School breakfasts and lunches. And in the beginning of the pandemic, when we first went to distance learning, I know many of the schools were actually still providing breakfasts and lunches, provided that the families could come pick them up. But many of our families have transportation problems, and I don't actually know of any schools still providing breakfast or lunches to low-income students. Medication management is also something that people probably aren't really realizing, but a huge percentage of our students get their medications at school, such as breathing treatments or ADHD medications, and as a result of the distance learning, may not be getting their medications as reliably as they were before. In some schools, vision or dental care or vaccinations are also provided, and with distance learning, those aren't being provided either. And then psychological services are available in most public schools and are heavily utilized by the older children and adolescent population, and those are currently unavailable to students. So this kind of going back to our development discussion, age 3, you have your first peer-to-peer relationships. And as you get older, you have a desire to associate with your peers, you form friendships, you have increased independence from your family. And all of this is changed dramatically in the context of a Zoom class with all of your classmates being on there, whose faces you can't see and who you can't talk to. Early social interactions with peers actually help develop strong language skills, creativity, empathy, and communication and confidence. They learn cooperation, conflict resolution, and they learn to interact with others who are different from themselves. They become more aware and tolerant of alternative beliefs, cultures, and family structures from their own. And early social interaction can dramatically improve vocabulary. For example, between ages 3 and 5, a child's vocabulary should grow from about 900 to 2,500 words. In children who are in preschool or other social programs such as daycares show dramatic improvement or a dramatic increase in their language boom, as opposed to children who aren't in these structured environments. So social interaction is actually good for school performance, which you might not think so. You might think, oh, if their peers aren't there to distract them, then there's nothing to keep them from learning. But their increased peer-to-peer and student-to-teacher interaction actually increases participation and engagement in the material. And increased face-to-face time with teachers helps ensure understanding. For example, if I was giving grand rounds in person, I could probably look into the audience and go, oh yeah, I've lost them, they're gone. But with the Zoom structure, teachers are unable to look into the audience and see, oh, there's a deer in the headlight, look, I better go over that again or rephrase that. Additionally, kids who are attending school early get a more accustomed to the structure and comfort with rules. Early structure and socialization helps improve school readiness in preschool children. And then social preening is a really important process that happens in older children and adolescents, where basically they get feedback from their peers when they do something or say something or act a certain way, and they learn, oh, I'm not going to do that again, or yeah, that got a chuckle, I'm going to do that again. And they alter the way they behave in order to meet the expectations of their peers. And this is a process that isn't happening in person right now, and is actually only happening online, which is probably not the way we want any of our teens to be socially preening. Also, school is a primary form of interaction for some who may not have peers in their neighborhood or have anyone else they can associate with. And they are now doing without this, and social media is taking the place as the primary form of social interaction. So you might have looked at that last slide and gone, oh, that can't be good for mental health. And it's not. And in fact, COVID-19 in general obviously has not been good for mental health. There's been a dramatic increase in suicidal ideation in the 18 to 24-year-olds per the CDC. If you look at this chart, you can see compared with 2018, where only 10% of young adults had suicidal ideation in the last 30 days. Here in August, almost a quarter, or over a quarter, actually had suicidal ideation in the past 30 days. 75% of 18 to 24-year-olds are struggling with a serious mental health issue, compared with 40% of adults in general. And this could include PTSD, depression, anxiety, bipolar disorder, or a host of other problems. And again, these kiddos don't have access to guidance counselors anymore. And many aren't coming into doctor's appointments for mental health follow-ups. Younger adults, racial and ethnic minorities, essential workers, and unpaid adult caregivers have had the most adverse mental health outcomes, increased substance abuse, and elevated suicidal ideation, which makes sense because this is the group experiencing a big strain. And then younger adults are have less coping mechanisms and have less access to guidance counselors and their peers, which typically are their kind of sources of strength during difficult times. Also, people, not just teenagers, are spending more time isolated or online. There's in the US, we don't have very good real-time data for tracking suicides. But if we look at two examples of countries that actually have very good, robust suicide tracking, Japan and Australia. In Japan, in October 2020, there were more deaths from suicide than from COVID-19 in the preceding 10 months of the pandemic. These suicides were up 80% in women whose jobs were actually those whose are primarily affected in the food and hospitality industries. Whereas in Australia, there didn't seem to be an increase in suicide since the start of COVID-19 at all. So it'll be interesting. We may not know for decades how COVID-19 has really impacted suicide rates in the US. There's speculation that maybe there will be that initial pulling together effect, like we experienced after 9/11, where there's a sharp decrease in suicides for a few months and then a steady increase for years to come. But we'll have to see. And then the last thing I kind of want to mention about mental health and COVID-19 is childhood trauma. The NYU actually had a great definition of trauma that I couldn't have painted a better definition for COVID. Traumatic events are typically situations that are out of our control, beyond our usual experience, and cause us to feel as though our lives or the lives of others may be in danger. These kiddos are hearing worrisome news on television. They may have experienced loss of loved ones. And then their take on COVID is largely due to their caregiver's response. So many kids here experiencing COVID, their world's been kind of turned upside down, just like the rest of us. But they're looking to us to see how they should respond, just like the 4-month-olds who are looking for that nonverbal communication to tell them it's okay. Kiddos are looking for us and to see how we respond to COVID in general. So again, from NYU, if a child's caregivers are relatively calm and reassuring, this is actually a protective factor. But if, on the other hand, caregivers are overwhelmed with their own worry or grief, it can be hard to provide the reassurance that children need. In the beginning of COVID-19, pediatricians were loudly stating that we needed to kind of modulate our response to this with respect to how it's going to impact our children. And we said, don't have the news going 24/7. Talk about this calmly. And as the number of cases rose and as the number of fatalities rose, we sort of hushed out of respect for how big of a deal that COVID-19 has been. But I think it's time for us to, again, look back at the children who are being affected by COVID-19 and kind of modulate the disaster of the pandemic with the disaster of the PTSD that these kiddos may be facing. It's also important to remember that response to trauma is different with different stages of development. So this is an example actually from our prep questions with regards to death in a family, but it has to do with trauma in general. Infants and toddlers don't understand really what's going on, but they have a difficulty with change in routine and are affected by distress of caregivers. So for these kids, it's important to keep routine the same as much as possible. For preschoolers, they engage in what's called magical thinking, where they basically think, oh, I was bad last week, and so COVID-19 happened. So my mom lost her job. They see themselves as the center of the world and don't link cause and effect well. This is the group that is particularly vulnerable to kind of internalizing thoughts that COVID-19 is due to something they did. School-age children, kind of around 6 to 12 years of age, are focused on fairness and individualization, and they'll usually focus on the fact that this isn't fair. Why did this happen to me? And they'll also worry that things that have happened to other people may happen to them. So if they've lost a loved one, they may be afraid that they also will die. Or if a friend's family member has lost their job, they may fear that their family member will also lose their job. And then adolescents, again, have a greater ability to kind of understand what's going on and consider existential ideas and think into the future. But they also are still pretty self-centered in much of their thinking and focus on how negative events impact their life. So it's important to remember as we're helping children at various ages that they are processing COVID-19 differently. And it's important to be aware and help families be aware of symptoms that a child may be struggling with post-traumatic stress or with depression or anxiety as a result of the pandemic. So if a child starts having nightmares or changes in sleep or appetite, we need to be screening these kiddos and talking to their families and seeing if maybe there's something deeper going on in terms of how they're processing this stressful event. So how has COVID-19 affected children? This kind of cogwheel mess down here is my attempt at showing that basically everything is related for kids. So if something impacts one aspect of their life, it impacts every aspect of their life. And my message today in talking about COVID-19 and children and what we as pediatricians can do, my suggestion is basically that we
just calibrate.
So that's my playful way of saying we as the pediatricians need to help modulate the programs that we were instituting to kind of help combat COVID-19. So we need to continue social distancing. We need to continue mask wearing, but we need to advocate for schools opening. And this may mean going toe-to-toe with some teacher unions, which is probably not the first time that pediatricians and teachers have disagreed on something. But this is important for our students to get full access to the school services and to face-to-face instruction. We need to follow up with our patients who are receiving therapies or should be receiving therapies and make sure that they are receiving them and make sure that we don't have additional families that we need to refer to therapies as a result of them falling behind. We need to screen for substance abuse, depression, and suicidality, especially in our adolescent population. We need to connect families with resources for food and employment, and we need to educate the community on signs of abuse, neglect, and trafficking. We need to talk to families about coping skills, how to get through this, how to help their children get through this. And lastly, we need to remember the global impact, that what we do as a nation impacts children, not just here, not just in East Tennessee, not just in the US, but across the globe, that children are suffering as a result of COVID-19, and that it's our duty to be their voice and to call attention to the pandemic that's occurring for them. And that is my my presentation. That these are my sources. Any questions?
Hi, yes, this is Dr. Johnson. I wanted to, you had mentioned about food services. I know for the region, Washington County is still doing meal services for students.
Oh, okay, that's good. I wasn't aware. I know the food banks are still open, but I haven't had a chance to talk with any students who are actually still receiving those services. So Washington County is.
Yeah, they have. I think I receive updates through a couple different platforms, but they have several drop-off points and places where students and parents can pick up meals. And it's not just for students who are eligible for free and reduced lunch. It's also students for any student that goes to the public schools in the region.
Oh, that's excellent. Okay, thank you so much.
Hey, Amanda. I thought that was an awesome presentation. I just had a question. I know our understanding of COVID is kind of evolving always, but there was a recent fairly large study on adults showing kind of a very high prevalence of persistent symptoms after illness. I know there's been, a couple case reports on pediatrics patients, but I was wondering if you would run across any information on like long-term effects of COVID itself in the pediatric population.
Other than kind of the new data on MISC, I haven't seen anything else about long-lasting effects on children. So, like for example, the adults with kind of the continued loss of taste or smell, or continued pulmonary issues. I haven't seen anything about that on kiddos themselves.
Okay, thanks.
I guess it's such a small population that we're trying to study across the US that it's going to be a while before we get more of that data.
Yeah, that would be hard data to pull together. So
yeah, we're looking at 11% of the population, and so I hopefully there'll be some bigger center studies on that. Any other questions? Okay, if not, thank you so much. I hope you guys have a great day.
Thanks for an amazing job, Amanda.
Thank you.